I'm going to call this meeting to order. So can we stand for the Pledge of Allegiance? Okay, I think we need to do roll call next.
Yes. Gonzalez,
Present.
Zunino,
Present.
Smith is absent, Manfredi is absent, Escobedo.
Present.
All right, we are here.
And I think we have to open it up for public comments, and this is the opportunity for the public to talk about any topic that isn't listed in the agenda. Do we have any comments? I think everyone here is a Stacks person. We do have Zoom for this, no comments for Zoom, right?
No public comments at this time, Chair.
Great. So next we'll move on to new business. The first is to approve the meeting minutes from the last meeting. I have to take public comments on this, correct?
Yes.
So are there any public comments on last meeting's minutes? I don't see anyone.
And none on Zoom, Chair.
And do we have anything to discuss? No. Do either of you want to make a motion to approve the meeting minutes from last time?
I'll make a motion.
I'll second.
Great.
All right. So I'll just do a roll call vote. Gonzalez?
Wait, is it yay, right?
Yeah. Zunino? Escobedo? That motion carries.
Great. So now we'll have the Stacks update presentation. Chief, do you want to introduce your officers, or do you, this is your first meeting, I realize, so.
Right, and I'm still getting used to the microphone thing as well. So, hi, I'm
It's
Jeff.
up to- If it's up to you, how you want to
I'm
do this.
Jeff Robertson. I'm the new chief. I've presented in front of the PAC before, but this is my first time as chief. This is Officer Matt Hazlett. He's pretty much the glue that holds our Stacks program together, and he's got some guests with him. Go ahead.
That's a good first introduction. Go ahead.
Does this do the slides? I'm assuming. Cool. Okay. Yeah, so I'm Officer Hazlett with South Lake Tahoe Police Department. I run the Stacks program. Stacks stands for South Tahoe Alternative Collaborative Services. I'm going to kind of do a big overview of kind of where we began, what we do now, and what we're looking at in the future. I'm going to discuss like partners. Kind of the big things I work on are the unhoused population and mental health response. And like I said, we're going to go through what we've done, how it started, and all that, and then what's coming up. So the key partners are going to be El Dorado County's Behavioral Health, the hospital, Tahoe Homeless Coalition, Fire and Rescue, Sheriff's Office, District Attorney's Office. We also have Sierra Mental Wellness, and there's a lot of people on there that it would probably take about 2 to 3 slides to put everyone. So I kind of just put a lot of the ones that we work with a lot together, and I should probably add on there Clean Tahoe because I'm with them every single day. So. For the housing for the unhoused population, kind of my goal is to get people off the streets, whether it's going to be short-term housing or long-term housing. Stacks is kind of good at being like the bubble in the middle, and I know where to reach once I know a little bit about a person. Our main options are going to be the coalition. There's drug and alcohol rehab through El Dorado County SUDS program. The shelter down in Placerville, and family reunification. Out of all those, the one that we use the most is going to be TCH. For mental health, As Stacks started off, we were doing a lot of joint responses with El Dorado County Behavioral Health. We had clinicians come out with me or with other officers, kind of making it more available to get a clinician out into the field with us. We were also doing a lot of follow-up on people that maybe were, frequently calls for service for the police department or for El Dorado County's behavioral health, and actually going out to them and trying to get them into services there. We were also doing follow-up on anyone that was detained on a 5150 hold. Now, as of, I believe, April, we have Sierra Mental Wellness, and it's really turned into kind of a referral system to them. And it's great because law enforcement, I don't have the numbers with me, and maybe someone in this room does, but now a lot of our mental health calls, rather than sending police officers out to, whether it's me or just a regular patrol officer, we're able to have Sierra Mental Wellness respond, whether that's by phone or in the field. And obviously we still work together. If they need follow-up or anything like that, it'll usually come through my desk before we actually move out. I just put some stats together. Since April of 2023, which is when I've started, I've handled 1,394 incidents, taken 191 reports, and made 116 arrests. Some of the information for housing and SUDS referral. So the coalition, I've referred 48 people into there, whether that's, once again, long-term or short-term housing, whether that's just their shelter when we had the shelter up or actually getting into one of the units there. I've changed about 3 different times how I've tracked my statistics. So believe they're all in there, but I could be missing a few here and there. I got a pretty solid program on that now, though. Same thing with the navigation center, which is the Placerville shelter. That one's not used as much, just because of the distance. Either I have to drive someone down there, they have to come up here and pick someone up. TCH will maybe get them a bus pass. It's just a lot more to get someone down there versus when I'm able to bring them down right down the road over here. So, and then family reunification. We've had 4 for that, and so that's going to be like a total of 77. Something I'll get into in a little bit, as you see on the referrals down there, we have Barton Addiction Medicine. In the last, I'd say year and a half, I began working with Barton's Addiction Medicine team and doing referrals for them. And we have pretty big plans in the future. I'll get on to that. I think it's the next slide. Sometimes just taking someone off the street and saying, hey, I can help get you an appointment, or they don't know that the resources are there, kind of thing. So, and then SUDS, where we have 4 on that as well. So the thing that we're looking to work, or that we're trying to establish now, is working very closely with Barton's Addiction Medicine team. We want to do some street medicine, basically, bringing out through the addiction services, basically getting people help that wouldn't normally come into like a brick and mortar building. And this can include unhoused, maybe just people who don't want to go to the doctor. And we're kind of working together. It's a really long process. Can't really promise anything at this point, but myself and Dr. McNamara, who's back here, we've been working pretty tirelessly on it. In April, I went with her to a addiction science medicine conference in Denver, learned a lot about it and about how it works. So we have some pretty high hopes for all that. I think that's it. So that's kind of the presentation. That's kind of just a real round overview of what Stacks is doing, what's going on. Yeah, and if you guys have any questions, after that, I also have some people who, I have Dr. McNamara here, and then I also have Kim Peterson from TCH here to speak as well.
I have a question or two. First off, thank you for your presentation. Maybe I missed it. What was the period of time the stats represent?
April of 2023.
Okay,
Until
from
now.
April to present, approximately, okay, all right, thank you, helpful. And then the street medicine, what all would that maybe entail? What is maybe possible in terms of what you're
Well-
learning about there?
I don't know. Liz, would you like to talk on this? I feel like Dr. McNamara would probably know a lot more. Yeah, want to come up?
Hi, I'm Elizabeth McNamara. I practice emergency medicine and addiction medicine at Barton. So a lot of, where do I start? Addiction is foundational to so many people's health, right? And a lot of people have access to the healthcare system previously with issues related to addiction or to mental health, and they've faced significant barriers such as stigma or difficulty in kind of putting things together, like where do I go, who do I see? With mental health being a Medi-Cal carve-out, we do have to do a lot of, okay, now you need to go over to the county building and establish care with them and then come back here, and there's a lot of sharing, and that can be really difficult for patients to navigate who have substance use disorders or mental illness, or often both. Our partnership with Stacks, I can't say enough good things about Stacks. The city has been a source of opioid settlement funds to support us growing addiction services at Barton. And so one of our dreams out of that funding is to take this, what's been sort of an informal partnership up to now, and really formalize it more with the idea that he knows everybody in town, he knows where to find them, but connecting people to a clinic appointment can be really hard to access, right? The date and the time and coming to the building and talking to the people and all of the executive function that it really takes to do that can be really challenging. So ideally what we would do is we'd have a predictable schedule where we'd have an outreach program with a van or another vehicle where we could provide basic medical care like wound care, blood pressure checks, basic blood work, just access to care in a friendly, low stigma, low barrier way, and include access to addiction care in that. So provide medications for alcohol use disorder, for opioid use disorder, provide linkages to care, like include the county and make it easier for people to access mental health, help people sign up with Medi-Cal services through that. And again, do that in a way where people can easily access it just by walking up and being like, hi, I'm here, instead of going through all the things to get to the clinic. What we learned by talking to a group that's been very successful doing this out of Chicago is that a lot of people just prefer to access healthcare that way, right? The model of if we build it, they will come does not apply to a significant amount of our population, especially the people I mentioned who are suffering with mental illness or substance use. And so they've realized that their model of having continued access in a mobile fashion has really helped with engagement and care. So we're at the planning stages, like what is the equipment we need? What does that look like? What are the expenses associated with it? We've had a lot of initial support, both from the police department and from Barton. Like, this sounds like a great idea. This is something we'd love to do. But as you can understand, there's a number of building steps on top of that. And what does it really look like? How do we staff it? We're really excited about it as a possibility, and we've been talking about it a lot.
And then I'd ask, is there some research you've seen maybe from other cities, other models, where you've seen improvements with reducing addiction specifically?
I can't speak to data that says, like, if you have mobile services, you'll decrease addiction, but we do know that providing medications to support addiction for people helps to save them and make them better, right? The less than 10% of people with addiction have access to appropriate medications, right? That's medication to treat alcohol use, that's medication to treat opioid use predominantly. And so just by having people have easier access to care, which we're really working on a lot at Barton, but through a model like this, we know that that will increase overall health, decrease illness and comorbidity associated with their substance use, and hopefully decrease the other social consequences around it.
Thank you for your effort, and thank you for sharing.
Thanks.
I don't know which one of you can speak to it. As far as funding for that, are you looking, is that going to be more localized funding, or are you going to branch out towards state, federal, or have you even gotten to that point yet?
I think we can support this with our local funding through the opioid settlement funds, and I don't know what your understanding is of how that funding infrastructure works, but we have agreements with both the city and the county to provide these services. And for the most part, right now, that funding is supporting the Navigator program at Barton, which I'm directing, which is that we have substance use navigators. We've had one for 4 years. We're bringing on a second one, so we have 7-day-a-week coverage. And those are basically care coordinators to help patients with substance use get to appointments, navigate their prescriptions, get refills, meet them in the hospital, help to just kind of set them up. So for the most part, that's been supported, but that's a sustainable program through Barton. And so that would be a sort of redirection of those funds towards this effort. And I expect that it would cover not only equipment costs, which would be sort of a one-time thing, but also personnel costs. And that would be shared probably between Barton and the grant money, and I don't quite know how that works. One of the things that we're seeing and we're worried about is there are going to be cuts to Medicaid, and that's going to impact a significant amount of our patient population, because I have a lot of patients who really fall in that gap. They're not definitively homeless, unemployed. They are employed, but they're relying on Medi-Cal for their health insurance. And so purchasing medications to support those patients may be a way that we are going to use our funds. It's going to be like a month by month, year by year decision, but I am not lacking for funding at this point. And we'll see. Eventually we will be. Yeah.
That was gonna actually be related to my question, if you guys were impacted by loss of federal fundings at all in the beginning of the year?
Oh yeah, I mean, I got a stop work order very soon after this presidential administration started, because I was receiving grant funding through the California Bridge Program, which is really what's enabled us to do the foundation of this work. And there was a threat to a grant that we had applied for in, what year is it now, 2025? In 2024. We ended up getting payment on that grant because it was dispersed from SAMHSA prior to the start of the year, but there is going to be no more funding from that source, and we won't be able to expect any more state funding, which comes from federal funding from SAMHSA, for the foreseeable future. The good news is that the opioid settlement funds are a sure thing, because those are not federally controlled funds. They're from a private lawsuit. And so that will be sustainable, and we have those agreements at least over the next 5 to 10 years.
Okay, and then just as a follow-up, last time y'all presented for us, I believe it was you who was doing the grant management. Is that still the case? So you guys are still lacking
Yeah,
a
and we
grant
talked
manager?
about that. So Barton has offered a lot of support for that, because I really kind of came to them and said, like, hey, I don't really do finances, and I practice medicine, and I need some help. And so I have staff at Barton that helps us to process all of our invoices to the city and county, and to, you know, get us paid and help keep track of funding. So that's been really, really helpful over the last year. Just the accounting part is really good. So that's no longer a problem.
Your program sounds great. I know you said you're modeling it after the Chicago version. Have you seen success in more rural communities like ours?
Yeah, absolutely. So we really latched onto the model from Chicago because they are very well organized with what they're doing, and we found their team to be very accessible. But there were several presentations from people who were doing street medicine outreach in much more rural settings, including with Native populations, and they've had similar successes. I mean, the same type of person exists everywhere, right? Has a difficult time accessing healthcare. And I have to admit, I had some early skepticism, like, can we do this in a small town? And after really hearing from these people and considering what it would look like, I mean, we have 20,000 people in town who don't have a primary care provider and who don't access healthcare on a regular basis. Like, I think that's probably enough.
And then my second question actually has to do with that, with access to care in general is difficult in our community with so many limited primary care providers. Are you guys planning to hire more of those to support this clinic? And you mentioned care coordinators, so you're following these types of patients, because that's a big issue in addiction medicine, is people falling off the record and then you're having to find them again, and it can be very complicated, where if you have social work, it's super important to make sure they're getting the care and following up on everything.
Absolutely. So I can't speak as much to primary care. I split my time between the emergency department and the outpatient clinic, where I only do addiction medicine. But as part of that, I do end up doing a fair amount of, I guess, what you would call primary care for patients, right? Immunizations, blood work, stuff like that. I know that they're working really hard to try to close the gap on primary care, and it's not going to be a problem that I think is going to be solved at one point, but it's going to be an ongoing thing. My thought and belief is that a lot of people are entering the system through addiction care. Like the predominance of patients I see for addiction medicine, I'm their first healthcare contact aside from the emergency department in years or decades. And they're predominantly concerned about their alcohol use, right? They do need a primary care provider. They do need their cholesterol checked and they need their immunizations, they need their colonoscopy. And to a certain extent, they need help getting out of bed and going to work and stuff like that. So I think that expanding addiction medicine services is going to help close the access gap, but I have persistent concerns that we can get everybody into primary care. And it's a little bit of like the finger in the dam phenomenon, where I just do everything I can to take care of people. And I think I can say the same for a lot of providers around here.
I think you have other people, so I want to allow space
talk
for.
all night.
I have more questions for sure, but I also want to give a
come back. I'll sit down.
chance for everyone to be able to speak too.
Sure.
Because I know you had a lot behind you.
Okay, go ahead, I'll do that.
That's why I brought her. So.
Yeah.
The next person I had was Kim Peterson with the Homeless Coalition.
Hi, good afternoon. I want to again say how fabulous our partnership has been with Officer Hazlett, and I've worked in other communities, and he really is like the epitome of how this is supposed to work. The program has been amazing since he came on. We have fantastic relationships just with our clients due to the fact that even if he arrests them, they still, some reason they still like him. So I just want to reiterate that, and I'll take any questions that you have.
I think my biggest question is based on last time you were here. I know this partnership is working really well, but are you still seeing that this program is helping to reduce arrests? Because I think that last time was like the commission, we were really supportive of this because it's helping reduce people entering to the criminal legal system if they didn't have to. So I just wanted to hear a little bit more, and I think just to have it on the record for everyone, how it's been helping to reduce arrest and entering people into the criminal legal system.
Yeah, absolutely. The more and more folks get housed, the less likely they are to enter the criminal justice system. We also, our case managers work with them to make sure that they're attending any court dates that they have, or to really resolve some of the current issues, and just staying out of trouble in general. I don't know data if it's really decreased in general, but again, we talk about certain folks often that police are like, what happened to that person? I'm like, oh, well, they've been housed, so they haven't been out causing issues. And we continue to work together on resolving encampment issues, working toward getting people housed, so again, that they aren't out setting fires or causing other issues out in the meadow that would lead to arrest or even just citations. The next thing we're working on with CalAIM through Anthem is a sobering center, which will be working closely with behavioral health and police to have somewhere for people that are frequent users of drug or alcohol, instead of them going to the drunk tank or being arrested, they'll come to TCH and then sober up and be offered services. So that's something we're looking at toward the end of the year.
And then TCH, have you all been impacted directly by the federal funding that has impacted your ability to partner in stacks, or?
So we only have one grant that is federally funded. And like Dr. McNamara said, we had a brief moment where everyone's freaking out not being able to get paid. But those funds did open back up. It really only impacts a small portion of what we do, a domestic violence rapid rehousing program, which is very important, but again, it's not our major funding source. We have been expanding our services dramatically through Medi-Cal, and so that's really unknown right now what is going to happen between now and 2030. So we don't have any information as of yet, but if this does people end up being kicked off of Medi-Cal, it will definitely impact our services.
Other questions right now?
Thank you.
And then we also have Chris Kearns here too from, oh, do you not want to talk? I saw you're here, so.
Hi, everyone.
Go ahead.
Chris Kearns, Behavioral Health Deputy Director. So I think my role is really in kind of giving you more update on where we're at with our partnership with our local law enforcement, which is very, very exciting. So since April of this year, we've launched Mobile Crisis Team in both slopes. So that's a 24/7 mobile crisis response for those who are having mental health crises. So back in the day, Matt described it, right? Like they will get the call, they will co-respond together with a mental health clinician, a mental health professional. Since mobile crisis respond now is in place, right? The idea is we staff the mobile crisis team with mental health professionals, which means, right, when we get the call, we screen the person, we identify the crisis, we decide, and this is the determining factor of would that response be co-response with law enforcement, or can they just deal with the crisis either on the phone or them dispatching in person? So since the launch, we've actually seen significant reduction in co-response with law enforcement, which really helps us redirect their efforts to actual criminal activities in the basin, right? So this also reduces strain in our hospital beds, because back in the day, somebody's going through a crisis, they just show up in the ED, as we know, Dr. McNamara know, right? Like our ED is so small, right? They can't really house all of those folks. So now we're able to respond through our mental health professionals wherever they are in the community. The good news about mobile crisis benefit is it is a medical benefit for all members of our community. It doesn't matter whether you have private insurance or you have medical. When you're having a crisis, you call mobile crisis, we will respond, whatever that means. Sometimes we will call Matt and be like, hey, we're not really sure, there's a weapon involved, or the client is not answering the weapon question. Can we co-respond together? And then another good news about this is part of the response is the 72-hour follow-up. So every dispatch, every encounter has to be followed up within 72 hours. Within that follow-up, it's either linking them to resources within our community, whether it's mental health, whether it's human services resources, benefits, other sort of services, medical resources, things like that, and then linking them to whatever is appropriate at that time. So every encounter, if they are not deemed necessary to go to the hospital, that encounter will end in a safety plan and a follow-up. When they end in the hospital, we also do follow-up and make sure that they ended up in wherever they need to go. So when they get to the hospital, our mental health clinicians are still doing those crisis assessment. They determine, appropriate for inpatient psychiatric services or going somewhere else. So to date, I actually was highlighting this because it's a really, really indication of the benefits of mobile crisis team in our community. As of April 3rd, since we launched until yesterday, we've logged 732 calls this is not just South Lake Tahoe, so it's all county, because we have two teams, both one here in South Lake Tahoe and other on the West Slope. So out of that 732 calls, 175 urgent calls, which rose to the level of mobile crisis response, and they were dispatched, so we dispatched our mobile crisis team there. Out of that, 30 calls were directly from local law enforcement, or we asked them to support us. And then another 30 of those calls were clients were transported to the hospital or emergency department. Any questions?
Maybe a quick question just on the sequence of if there's a typical. So would a person contact you directly, or does it go through dispatch? And then to you, how is that part in place?
Very good question. Yes, so we have our mobile crisis number, which is 24/7. It's 530-622-3345. I memorized that. So when we receive the call, right, our answering service will screen the individual. There's a form that the state release, and that includes safety questions, risk assessment questions. And then from there, they'll transfer them to our vendor, their mental wellness group, and then they will either de-escalate over the phone or respond with just them or co-respond with law enforcement. And then vice versa. The other route would be 911, right? 911 will end up getting the call, and then they determine that it's a mental health crisis. Then they will connect that to our answering service, and then we'll do the same. We'll assess for whatever response is appropriate for that situation, and then we respond that way.
Yeah, thank you. Thanks for sharing that. That makes sense. So, so most folks in the community use that first number instead of dispatch? Am I understanding that?
So the number is our answer. So the 530-622-3345 is our 24/7 mobile crisis number. So that is the number that we share with everyone. This is the number you're going to call, and that will be answered by an answering service, and then they're the ones who's going to route the call to our vendor so they can respond.
Got
Did
it.
that answer
Yeah,
your
that
question?
does. That does.
Okay.
Thank you.
I guess I have two questions. To clarify, on the stats that you provided, was that from April of this year?
Mm-hmm.
And then a follow-up on Justin's, on the phone number, I'm thinking maybe outside the box. I don't know if you're having a crisis. I don't know that I could remember that number. I would go, do you have stats on how many went through 911 versus how many went through that number?
We don't actually.
Okay.
We don't know that data, unfortunately.
Just like, thank you.
We might be able to pull that. Maybe.
Thank you.
You're
I'll let you
welcome.
do.
I guess now with the addition of Sierra Mental Health, which was an exciting addition, how has that changed the distribution in your response? Has it alleviated it? Or I guess what I'm trying to understand, what are the biggest changes since bringing Sierra on?
Say that again, sorry.
Like, what are the biggest changes just bringing Sierra on? Because I know El Dorado County Public Health was the primary responder, right? So
Yeah. So like we were saying in the beginning, we were really partnering up. I was over at that building all the time. They were at the police department all the time. We're going out in the field quite a bit. We just don't need to do that anymore because now we have a mobile crisis response team, here in Tahoe. They're here 24/7. So even if I'm off duty, or if there's none of the clinicians from behavioral health that are available to come out, that team is always there. So that is kind of now turned into the first response that they're going to do, and kind of going back to these other two questions about like with the numbers and stuff. Oftentimes it's not just the people that are calling because they need help. A lot of times it's family members, friends, someone driving past them and they see someone doing something's happening. So a lot of those are going to go through whether it's 911 or dispatch or whatever, and then our dispatch contacts Sierra Mental Wellness, and then they can kind of handle it from there. For me personally, in my position, it feels like I have had a huge part of my workload taken off my plate. Those just trying to do the follow-ups just on people who had been placed on a mental health hold, or if we thought this is something we need to follow up on, even if they weren't committed. That was very time consuming. That was a lot. I had files and stacks, and we're having phone calls and going through who's what and trying to keep up with the time frames, on top of trying to handle the homeless, and sometimes there's just a lot of calls for service and I need to go help patrol kind of thing. So it's been huge as far as taking like a weight off of my plate. Like I'm pretty happy about it. So needless to say. So.
I just maybe one more note. It sounds like you're doing a fantastic job out there, and I tell you that matters. That relationship, that approach, right, matters. You're going to get more people take advantage of the service, right? Depending on the approach we take with people, especially that first contact. So kudos to you for, doing the great job you are with the program. So thank you.
Thank you very much.
I guess the last question I have is for you, Chief. And given the success of this program, is this still a priority as you've come in onto this to take ground of the ship? And where does this sit on priorities for you?
One, absolutely, it's a priority. The program that we had with the integration with Sierra Mental Wellness is you see the interaction between the police and those marginal calls, the mental health calls, those have decreased, those interactions have decreased. And I think that was one of the goals laid out kind of with the foundation of the Police Advisory Commission. And we've seen that decrease in those interactions. And I think that's one of the important things. I fully support the STACS program, and I don't see it going away anytime soon. I think we're going to have a need for it in the community for a long time to come, unfortunately.
Unfortunately and fortunately, because it's cool to see this partnership continue to blossom and continue to grow. Yeah, are there other presentations from you, from your team? Well, it's Ryan. It's good to meet you too, and see for the community to have names to these organizations and to see you all working so hard. So thank you so much for that. And I think I have to open up for public comment, but thank you for coming back and refreshing your presentation.
Yeah, thank you.
So, are there any public comments to talk about stacks? And anyone on Zoom?
No hands raised on Zoom.
Okay, well, now we can discuss this item. Yeah, I did write myself a cheat sheet on the order of operations. I definitely think, and I think as we're getting closer to our annual report, showing continued support for the STACS program, and hopefully the STACS folks know that if they ever need additional support, they can come and ask us. I do think that this is one of the more successful programs that we've seen applied in the community, especially in such a short time. So I think also having annual updates on how things are going is, I think, just generally helpful for the community to know. I talk about a lot of the perception of law enforcement in our community, and I really have always respected that Chief Stevenson, now Chief Robertson, really prioritize having this kind of response that doesn't always result in criminal intervention. And I just want to put that on the record. If anyone else wants to share their thoughts on how we can continue to support stacks, please feel free to do so.
I just share that I appreciate the innovation that's taking place, right, within the community, seeing the need and then ideas, applying things, check the success, metrics, how are we doing with it, revisiting, right, just the evolution that was just shared here with us today, right, where we started, where we are today, what are we thinking about in the future. Just kudos there in that innovative spirit of how can we kind of continue to circle around and improve what we're doing.
Great. Thank you so much. I think we are done with new business. So if you all want to go back, I think you guys can go home if you want to. I think the next thing on the agenda is staff reports and announcements. So I guess we'll start with.
I have nothing, Chair.
This would be your opportunity if you had any announcements as well.
I think the only thing I would appreciate is that I've been able to meet with a couple of the members of the board, and I'm looking forward to meet with the other members of the board, kind of discuss the future and the engagement of the Police Advisory Commission.
Anything from the city attorney?
Yes, just it was interesting to hear the potential future use of the opioid settlement funds, and I will be bringing a couple more settlements to council at the end of September. That money just kind of keeps coming in. It's from nationwide settlements against some of the opioid distributors and pharmacies that sold them, and the new one is with the Sackler family. So that money just keeps coming in, and I'm glad there's a good use for it.
Great, now it's time for our reports, and also this is an opportunity to set future agenda items. Madam Clerk, is the next meeting before or after the report is due? Can't remember the calendaring.
That's a good question. It's a good question. Let me see if I can get to my calendar.
Because I think if we have the opportunity to talk about what can be put in the report too, that would be good, because always the timing of that last one is off.
Yeah, I think the former chief and I went over that last
Okay.
time. So I think it's our intent to bring something forward to the PAC before it goes to city council this time. If not, the chief and I will coordinate so that happens.
So if it's possible, can we add that as an agenda item? Does someone
Yes.
want to second that?
I'll second that. We get it on as an agenda item.
Okay,
So
thank
do
you.
want me to say?
And then the other one is, Chief, you haven't had an opportunity to introduce yourself to this commission based on the timing of your hiring. So I was also thinking for the next agenda, if you would like to make an opportunity to introduce yourself and introduce your hopes for engaging with the Police Advisory Commission. I don't know if that makes sense as an agenda item, but.
Yeah, I'll bring my hopes and dreams.
But that was my other idea for an agenda item for next time, is to have a formal kind of introduction of you. Does anyone want to second that one?
I'll second that.
Any other ideas for future meetings? Those feel like two big ones for an hour meeting, so, yeah. Okay. With that, then I think we can adjourn.